Okay, now let me go into my presentation here. Okay, let's go background. Let me open that. Right. Okay. Can everybody see that? Excellent. Okay.
Looks good.
So we're going to talk about the proximal and phalangeal joint fractures. In short, we will call them PIP fractures. And just general overview, I'm going to present a case example, go over the anatomy, mechanism of injury, diagnosis, and some of the treatment options. So here's a case, 55-year-old falls off a motorcycle at a slow speed. 1 week later, shows up in my clinic with pain and swelling and cannot flex the finger. This is the index finger, sorry, this is the ring finger, and has difficulty bending. We get an x-ray. As you see, it's a very subtle change happening here. Just keep it in mind as we're going over the cases and discuss the options. We'll come back to it at the end. So anatomy. The PIP joint has a very complex anatomy in terms of their ligaments, and there is a whole tendon sheet that holds it in place, the flexor tendon sheet, the extensor system, and then what it actually creates is a box with a volar plate in the lower part of the box and the collateral ligament on the sides. This kind of create a solid box. So in order to dislocate, you have to do more than just one part of the box has to be broken. I always say it's like a banana. You cannot break a banana only just one side being broken. So in terms of PIP injuries, you can have a dorsal fracture dislocation, we can have a volar fracture dislocation, or we have a comminuted fracture, which is not a classic dislocation, but we call it a pile-on fracture. In terms of the classic fracture dislocation, basically there are two common. There are the dorsal and the volar. The volar is much more rarer, but the dorsal is pretty common, as you see in this picture. So in terms of volar fracture dislocation, there's not much major written on this other than a few articles. The one that really went over is way back showed that the surgery with either ORF or pinning, they end up usually with some significant flexion contractures. In most of the time, volar fracture dislocation is the central slip that evulses, either breaks or evulses off the base of the middle phalanx. And if it's not reduced, it requires reduction. If it can be reduced, you can treat them as a boutonniere injury, acute boutonniere injuries, and hold them in splint. So in a case of an ORIF, because a significant part of the joint was taken out with the evulsion fracture, and this is a technique of plating and kind of a buttress plating on top with a K-wire to hold it temporarily. Now let's talk about the dorsal fracture dislocation, which is the crux of this course. And they're basically been classified by Eaton with the Eaton type 1, which is just a dorsal sprain, so to speak, with a hyperextension. Type 2 is actually dislocation. And the type 3 is which a fracture dislocation. And the question is how much of the joint is involved in the fracture. A sub-classification of Eaton is the basically if it's only 15%, that's basically it's not much of a problem. As once it's reduced, you can start early range of motion, and then there's the 30%, and then up to 40%, and then 50%. Above 50%, it becomes very difficult to deal with this. So let's look at the deforming forces. Of course, the extensor tendon is pulling it up. Dorsally, the flexor digitorum superficialis is making the finger flex down slightly, and the volar plate is holding on the volar fragment. And in this causes problem because ideally you like to, when you flex, you want to glide the joint. But if there's not enough of a joint space left or joint subcondylar bone left, when you try to flex, you end up hinging, and that causes this deformity, which is causes stiffness and problems with arthritis and so on and so forth, and the finger doesn't work. And so the classic V sign, which is this little section where hinging causes this opening up to the dorsal part, as you see in this picture. And it's a very subtle sometimes and frequently missed in the ER by the ER physician when they initially see it. And I was personally involved in a lawsuit with just because of that reason. Here's another picture. You can see how this could be very subtle changes of this opening of the joint called the V sign. The more you look at it, the more pattern recognition you get, and you tend to remember this. Once you look at it, the V sign, go, it's trouble. Anyway, in terms of fracture dislocation, you also have to remember there's two parts. If it's the actual dislocation, there will be an intact part of the dorsal cortex. If the dorsal cortex is not intact, then it's not actually a fracture dislocation. It's more like a pylon fracture, which it's a whole different treatment protocol for that. So in terms of treatment, if it's less than 50% joint involvement, then active range of motion, it can be started almost immediately, but maybe resting for about a week. If it's more than 30% or 30% joint involvement, then we have a technique of dorsal blocking splinting, initially discussed with Dobbins and McElfresh from Mayo Clinic, which you can start early motion having a dorsal blocking to prevent dislocation. But if it's more than 30%, now we're talking about 30 to 50%, then we're talking about some surgical options, either pinning it, and there are different options in terms of open reduction internal fixation, Wallerped arthroplasty, or X-fix. And then when it's more than 50%, you need something to bring in, either a combination of the above techniques or a Hemi-hamate, as we will discuss later, or an external fixator. Dorsal extension block splinting was brought in 1972. This is a long time ago, and it worked. Reduction initially with flexion, and then once the PIP is flexed and reduced, you keep it from extending, and then allow to bend while in that limited range to fingers to start gliding, and then slowly over a week, every week to allow a little bit more extension. Here's an example, classic. Actually, this is a patient of mine. So it was dislocated, but you can see there's more than 50% is still there. So probably I would say 30% of the joint is involved. This is a perfect case for a dorsal block splinting. By flexion, it reduces very nicely. You see there's no V sign. And then you allow in this cage, by flexing the MP joint, that decreases the tension of the extensor tendon system and also allows it to move. So there's a little limited area so it can move. And he did pretty good by this way. Now, of course, the external fixator was being discussed all the way back from 1980s to now. Initially, Shen came up with the banjo spin, the big spin to allow range of motion, and then AG came up with a ingenious way of putting rubber bands to put counterforce, and then even Dr. Hastings came up with a splint, and then there's Suzuki technique we'll talk about more in terms of traction. Here's a banjo splint from Dr. Schenk. It did work, but it's not an easy thing for a patient to carry this big circle around, especially putting clothes on. Then there's wire external fixator with dynamic traction. Again, sometimes there's not much a hinge left there or not much of a joint there to even try to do anything else other than put an external fixator, put some traction, and that allows it to heal pretty good. And just a follow-up in about 3 months, his traction is off, even though it's not perfectly aligned, but he has good motion. So there's this Suzuki frame. Suzuki described this in 1993 with almost like a portable traction. The pins are put across the joint line, right in the hinge, right at the center of rotation, and then another K-wire is put in. So as the this metal comes down, it pushes the needle failings down and reduces it, and then you got the rubber bands to keep the traction to allow early range of motion. A PIP joint, AG came up with this initial system of counterforce and torque devices, and now he's got it commercially available systems like PIP FX, which allows it again to hold this torque system and put it in place. But these are only really work for smaller fragments. There's a dorsal blocking splint where once you reduce it, allows the dorsal blocking splint or a pin to go in the condyle of the proximal phalanx. This way, you would preventing from dorsally dislocating the fracture. The problem, of course, is that it's hard to start early range of motion with the pin in place because the pin is spears through the extensor tendon, and it's not allows it to really flex and do early range of motion. But that has been explained or published on this. And then, of course, there's the open reduction internal fixation and the option of volar arthroplasty or hemi-hamate reconstruction once we are opening the joint. Once we open the joint, the classic opening is a shotgun technique where we allow the finger to go completely parallel and by hyperextension. This allows it to actually see the joint well, and you see what to do. We can decide to bring these fragments up and put a screw or plate or do a hemi-hamate. Here's an example. Again, 15-year-old was hit by a ball in water polo. Very subtle. It's just you have that V sign and it's dislocated. This we tried to open it up and put a little small plate with screws. I tried to put just the screws, but you need a little bit more stability. There were too many combinations to just do the screws. Of course, he 9 months later, he was left with some 25 degrees of flexion contracture, but he's happy, he can flex and go back to his water polo. And then, of course, there's the volar arthroplasty. 1980, Dr. Eaton presented this with some cases where they showed that by advancing the thick volar plate, as you see in this picture, the volar plate is pretty thick, cartilaginous, and that can be taken off and then advanced into the defect to allow both a buttress from going further up and also resurface the cartilage. Sometimes there's actually damages in the cartilage that having the volar plate helps. I can see in this right lower corner picture, the volar plate is thick, stout piece of fiber cartilaginous tissue. By putting sutures and through with a keyed needle through the base of the middle phalanx, we can resurface the area and hopefully hold it in place. Now, of course, most of the studies show that this actually works best only if you have a defect less than 50%. If it's more, then it's going to be difficult for it to work ideally. Here's some pictures of the steps. Once you take the fragment out and you get the volar plate, you can mobilize the volar plate by slightly reset the screws or the legs of the attachment and then bring it into the defect. And it's important to be right at the cartilage level, not any deeper. And then you either put a button in the back or tie it over a button over the cortex. So I did a study when I was my fellowship with Dr. Eaton in 2000, and we went over a long-term follow-up of this on the average of 11 years, and patient did pretty good. It's amazingly some of the bone actually reformed in that volar plate. As long as the case was done early, within the first 4 weeks, the results were pretty good. Of course, once it's past 2 months, it gets harder, more contractures develop, and it's hard to overcome them. And then best results were the cases where the fractures were less than 50% of the joint. Of course, there's the hemi-hamate that we will have more on later. This was introduced in 1999 by Dr. Hastings, and where you harvest a piece of bone, which just happens to be the same shape of the condyle. It matches the condyle of the middle phalanx, and we take that and then put it in there to reconstruct the defect or the lost amount of bone. So here's our patient. The 55-year-old had a motorcycle injury. We ended up doing an open reduction internal fixation with just 2 screws. And 4 months post-op, he's doing very good. He's got about 20 to 100 degrees range of motion. And I consider that a success for a case like that. So take-home message, remember, look for subtle signs of dose disruption. These are some things that is frequently missed, especially look for that V sign. Aim for a stable reduction. However, you can do it with a dorsal splint or surgery. And stabilize once it's stabilized, to allow early range of motion. They can do that with external fixator, pins, screws, volar plate, or graft. Okay, now I'm going to stop sharing and allow our sage to begin talk about his techniques. Thank you.
Thank you, Emil. See if this will pull on up. Thanks for putting this all together and for everybody being here for an interesting symposium. I hope to learn a lot myself from it. So I'm going to deal with just a small part of all this, concentrating mainly on biomechanics that will give you a clue on how to judge when things are going to work or when they're going to fail, and then maybe a couple surgical pearls. So as Emil said, these happen typically from a ball or an axial load that drives the base of the middle phalanx out, and then the head of the middle phalanx causes variable amount of compression and displacement of the palmar fragments. Tom Kiefaber and Peter Stern modified my initial classification. Those that are less than 30 are stable, and you can take them to a full range of motion. As Emil said, the tenuous ones are 30 to 50. They may reduce, they may not, but this tenuous group does reduce with mild flexion less than 30. And as emphasized, and to hit home again, those more than 50% or requiring significant flexion are considered unstable. Now, what is a 50%? You know, one of the problems in evaluating all the results of the dorsal block splint, the McElfresh and Dobbins, the Eden arthroplasty, the volar plate arthroplasty, and other studies is that what may look like a 50% can be deceiving because part of the AP diameter is central tendon and not part of the concave part of the joint. So the joint may actually be more affected on a coronal look or on a CT than just by the 50%. The other thing that's hard to figure out, sometimes ones that are 50% look like they work, or 60% look like they work. But that's because a lot of these that look like they're 50% occur from a deviation and rotational injury that affects one side of the joint worse than the other. So for an example, it may have large involvement on one part of the condylar facet and very little on the other. So it's really more stable than it looks based upon the stability provided by one of the condylar recesses. So this unstable group, percutaneous fixation is shown. Sometimes you can manipulate intra-articularly with a small K-wire to reduce parts that are depressed. Open reduction, particularly if you have a single volar piece, that can be very, very fruitful and just shown. External fixation. Osteotomy hasn't been mentioned, but osteotomy I'll show you in a minute. Sometimes the palmar impaction reduces and sometimes it don't. Sometimes you can tease it with an intra-articular or K-wire through the canal. And in late cases, Norm Zemmel from LA described osteotomies where someone is healed in a bad position and you can osteotomize and bring back that volar piece, restoring back the concavity to the joint. So as Emil showed, the joint tends to slip out. So these greater than 50%, all you have is kind of the upslope of the joint. This was a case in '83 that I personally did with Dick Eaton when he visited. And as you can see, the volar plate arthroplasty is handled, the joint's pinned, and then the minute the pin is pulled, it immediately redislocated. So again, it's the dorsal remaining slope with the lack of a guiding palmar buttress that causes these to dislocate. If you interpose something, they can still work. They can hinge on that apex and they can kind of flex and glide, but the apex will tend to block the digit from extending. The volar plate is 1.5 to 2 millimeters thick. So if you have very slight depression, the volar plate can make up for the slight amount of depression. So occasionally that can be a solution if there's just very subtle or slight depression of the volar part of the joint. This is a biomechanical study by Tyser and colleagues looking at an osteochondral graft versus the volar plate. And what they found is that that osteochondral graft can stabilize it through a full range of motion, but the volar plate arthroplasty required accepting or creating a flexion contracture so that it remains stable. And probably it's even not quite as ideal as it's shown here because the study didn't really axially load these joints. So way back some 20-something years ago, Ward Hamlet and I looked at what factors might create stability or instability, and also whether the presumed collaterals offered any stability to the joint. So this is in a nutshell what we did. We just incised between the proper collateral and the accessory collateral. And as Emil showed us, you can take a little divot away and it's totally stable. And in fact, you can excise up to 30% and it's totally stable up to 30%. And then you get up to 50 and yeah, it's stable as you extend it. But then as you flex the joint, it just tends to cave in, as Emil emphasized, into this defect. So in real time, this is kind of what it looks like when it presents to you. As you extend, as the joint comes up and out, it suddenly pops out into a dislocated position, and then it just hinges upon that volar defect. So we found that basically up to 42% of the joint gone. The joint, in fact, was stable in all positions. And if you look at McElfresh and Dobbins' study, they didn't really classify the percentage of articular involvement. But if you get a late case, if you just release the collateral so that it'll come back down into position, if it's 40% or less, it's going to be stable. And then beyond that, it requires increasing amount of flexion. And when you get up to 60%, it's going to be unstable, even in severe flexion. Collaterals don't provide any dorsal volar stability. So with them intact, cut, or cut and the finger dislocated, they were equally stable or equally unstable. Bruce Steinberg was very instrumental in kind of working out the details of the hamate in the lab with me, looking at taking the dorsal hamate and rotating it around into position. As you see here, here's a defect that we've created, and here's an axial view or coronal view looking at the hamate and the middle phalanx, showing similar bicondylar facets. And then here's the graft in position. So it restores stability. You don't need additional fixation. You can begin early motion. So the surfaces are similar. They're not identical. They are similar, and that's what lends this donor source as a solution. The graft's big enough that you can fix it with screws, and it's convenient because it's locally available. John Capo and colleagues with me looked at whether we were creating instability, and I was afraid naively that we might when we first started this, but we found that even after harvest, there's minimal instability even with axial load. So the indications are for these comminuted unstable ones, too comminuted to fix, and all too often it's neglected or chronic ones that present to your office. Is occasionally, not very often, but it may be just a pure deviation injury that ruins one plateau and not the other. And then I think all of us will find that we're faced at times with cases that have just failed other treatment methods. Contraindications, I don't know. They almost always have injury to the head of the proximal phalanx. And does this preclude using it? Not necessarily, but it does long-term maybe increase the chance, well, it does increase the chance of some radiographic arthritic change if it's really severe. And obviously you need good soft tissues, and it does, as Gary's going to show us, it does require a cooperative patient. So that's part of the game plan. Here's a patient that had been chronically riding on the dorsal part of the head of the proximal phalanx. And here's the graft applied, and then the joint functioning with the graft in position. So even a late case like this sometimes can work. This was a case that came to one of my partners almost 7 months out. And at first look, it looked like it was going to be too arthritic to really work. If you look at this lateral x-ray, it looks pretty ratty. It doesn't look very good. This is what he looked like. And yes, there was cartilage injury to the head of the proximal phalanx. here's his graft, and then here's the graft in position. There can be perfect matches, imperfect matches, and this is probably one of the better ones. And then here he is at 8 weeks after surgery. This is not too unusual. It's pretty easy to get normal flexion, and it is harder to get full extension, particularly if you're protecting the volar plate repair afterwards. I don't have experience with hemi replacements, but here's an example, and you'll find some in the literature where the head of the proximal phalanx is really arthritic, and then handled by a hemi-arthroplasty combined with a hemi-hamate, and in this case, published in May of 22, a good 12-year follow-up. Couple tips I'll give you. It is important to look at the AP diameter of the opposite hand equal digit. That gives you a clue for how big the graft needs to be. I used to measure the donor requirements by a ruler, but now I use just a number of small osteotomes that I just put up. And that osteotome serves as a guide for estimating the size. And then you draw it out on the dorsal aspect of the hamate. It almost always is the entire width of the hamate. It's fine to take the entire width. I also take out a wedge of bone proximally, and that's based on, like a lot of what we do, one time something happening when the graft just extruded up to the ceiling. So this decompresses the forces when you cut. I'll show in a minute. So the angle cut is really important, and the way to do that is to remove the dorsal base of the fourth and fifth metacarpals, and that gives you good access to the joint. It's a fiddly operation, so it takes a little bit of work and effort to get it to fit properly. It does survive, I think, because it's cancellous and it's sizable. You can fix it, and very importantly, as I'll emphasize later, you need to correct the shear forces that lead to cartilage disruption. Early on, my attempts to make this coronal cut were through osteotomes, like these curved osteotomes, but it's so much easier just to remove the dorsal base of 4 and 5. It doesn't articulate anyway. It doesn't create any stability changes. So you might be tempted to cut it from proximal to distal, but it's much, much better to cut inside the joint, going in a deeper path as you go proximally. So here's just a drawing I made just of where, if you took it like this, which is real easy outside the joint, and then you put it in, it's going to match like this, and it won't really restore the concavity. If you cut it like this, yes, then when you put the graft in, it automatically recreates that concavity that you want. You can also, I used to prepare the defect first, but I learned to do it later. You can also modify the defect a little bit obliquely, and that also favors tipping of the graft. And then lastly, if you have the option of leaving a little hinge or a little buttress distally, the graft just keys into a very stable way. It's easy to fix it with a 0.28K wire, and the core diameter of a 1.5 screw is 0.028 basically. So that serves as a core drill for a later 1.5 screw. We do over drill the graft, so you get a lag technique, and at times you may have enough room to put in a larger 1.3 millimeter screw. The larger the defect, the more difficult it is, and that's because the hamate, while it's similar, has a larger radius of curvature than the base of the middle phalanx. And so it'll lead to a flatter joint just because it has a larger radius of curvature. So the larger the defect, the more important it is that you accentuate the tip of the graft so it restores that palmar buttress properly. Otherwise, it'll create a flat joint that just wants to shift or shear dorsally and palmarly. There are a few times, I think only 5 or 6 times in my career, where I had to use a buttressing plate. One option might be if you have a little void that doesn't create as much stability. Another option is when you have like a 60 or 80% involvement, you may not have enough bone dorsally to hold those screws without them toggling. And a little buttress plate like Emil has shown us works really well in that situation. So this is a hockey player. And this is his 8-week follow-up, and this is not too unusual. Gary can show us how to get out of this flexion contracture, but he was happy. If you keep your fixation proximal, that's the best bone, number one. Number two, it allows you to resect this bony prominence after you put the graft in. So that's helpful. If you look at x-rays and even ones in this talk, you'll see that there's an apparent articular step off bony wise, but if you've been in surgery yourself, you know the cartilage matches up perfectly because the hamate has thicker cartilage than the cartilage at the base of the middle phalanx. The volar plate's easy to repair. It's very robust on the lateral margins, and there's always the accessory collateral ligament insertion that you can repair it to. You just need to be wary of the digital nerve, identify it, look at it, protect it while you put these sutures in. And then I usually do reflect the retinaculum between A2 and A4 pulleys deep to the tendons on closure. I have some other biomechanical studies that came from Canada that I won't show you, but this just shows the morphologic differences. Some look absolutely perfect, some are not quite as perfect, but with the cartilage it serves and bone, it serves as a good buttress. I'll skim over the outcomes. They're mostly similar. Extension deficit in my first study of 26 degrees, flexion to 90. The Cincinnati group, 87 degrees. Better results when acute than chronic. And then Bernier emphasizes, as I mentioned, that there's almost always moderate mirror images to the head of the proximal phalanx. Same thing with Verdun's, 82 degrees range of motion. 2 ended up failing with a silicone arthroplasty. And out of the 25 patients with Mina and colleagues, 1 had to be revised from a loose screw. They do seem to hold up. This is a patient that fell from a tree platform some 20 feet that came to me almost 6 months out. Almost 6 months out. And this is his reconstruction and the appearance at 8.5 years. And this is his motion at 8.5 years. So if you get it properly positioned and you restore the concavity, it can hold up. So the take home is less than 30%. It's a no-brainer. These are stable, and even up to 42%, they're stable. But beyond that, you have to hold them in flexion to maintain them in a stable position. And more than 60%, they're all going to be unstable. So there are a lot of things. Lots of times the external fixation will reduce what you need. So a lot of these more conservative techniques are worth looking at. When you see it delayed, then ORIF is probably the best option. When you can't deal with one of these simpler options, then osteochondral grafting is the best solution that I've found up. There will be other options down the road, I'm sure. Very, very important. I can't nail this in too repetitively. You have to restore the concavity of the joint. If it ends up too flat, you're going to get dorsal volar sliding motion and then deterioration of the joint. Intermediate results do hold up. We still don't have long-term results. And most studies do show some degeneration over time, particularly in late address cases, but that doesn't always correlate with symptoms. So in a nutshell, hopefully that'll give you a little clue on why it's so hard to tell if it's 30, 40, or 50, because it's not always a pure transverse or coronal plane fracture, and a couple of tips that may help you get past some of those problems. I want to get rid of that. Sorry. You still on, Emil? You're muted, I think.
You're muted, yeah.
I'm muted. Yeah, thank you. Thank you very much, Dr. Hastings. That was enlightening. I think now we can go with Dr. Harness to show us some cases of complication.
Okay. All right. Let's see. Does everybody see that?
Nope.
Nope.
Not yet.
No, not yet. Maybe near their screen.
Okay. Share.
There we go.
Okay.
Yep.
Get that back up. Okay, great. So thanks for having me. I'm going to be talking about the complications associated with these injuries. And really appreciate Emil asking me to be involved in this symposium. It's a real honor. It's great having a partner like Emil Dionysian. I want to just throw that out there. He's an extremely talented surgeon and a great resource that I've fallen back on and got advice from over the years. So I really just want to throw that out to you, Emil.
Thanks.
So I don't have any disclosures. So if we go to the next slide, there we go. This is a little bit of repeat, but just to reiterate what Dr. Dionysian said at the beginning, these are fairly common injuries, and our goals are really to recreate joint stability in order to prevent arthritis, stiffness, and pain. And the stability relies mostly on the size of the fragment we're dealing with, but a lot of it also is recognizing central articular comminution and how that plays a role in stability and how we deal with that intraoperatively. Natural history of untreated dorsal fracture dislocations, you can see here. Surprisingly, a lot of these patients do pretty well. I've seen a few long-term missed fracture dislocations like this, and for some reason or another, they do pretty well without pain for quite a while, but eventually make their way to the hand clinic to get treated. They largely are moving through a hinged pseudoarthrosis. They eventually develop, post-traumatic arthritis, pain, and stiffness. So it's better to get to these early. And again, I won't belabor this point, but again, anything over 50% is going to be unstable and need to be treated. The classic V sign you hear. This patient was trying. I think they were trying to treat this patient with a dorsal block splint, and the articular involvement is clearly at least 50%. I think we've seen this graph in the past also. The take-home message here is that there are a number of different treatment options, but if you look at the research out there, none of them have really been shown to be better than another. I would just state that volar plate arthroplasty really has a pretty narrow window of use between 30 and 50%. Anything over that, you're going to start to develop a flexion contracture. Splinting again is down in the under 30% range. That leaves ORF and external fixation for most of our fractures that need to be treated operatively, and then Hemi-hamate for those involving more than 50% or upwards of 80%. I prefer ORF when I can. If it's a simple fragment. If it's easy to fix with screws, that's great. I can get them moving early and things can go well. I can prevent the stiffness and post-traumatic arthritis that we see with a lot of these. These are just a few examples of the ways I've been treating these with volar screws. Also, a little mini plate volarly can be used to buttress the fragments. And then on the far right, this is not one I've done, but reports have been put out there on placing screws from dorsal to volar and fixing these volar rim fragments. So this is the first case I just want to share with you guys. This is a patient of mine I treated years ago, 50-year-old female. She was a sign language interpreter. She had twisted her finger. She had a fracture dislocation of the ring finger PIP joint. She presented with pain and limited motion in these x-rays. And what I want to point out, and is important to realize on this x-ray, is that you look at the x-ray and sure enough, there's a dorsal fracture dislocation. You can see a V sign, but there's a lot of central articular depression, and the volar fragment, which we'll see in the next slide, is very thin and not very stout. And in the coronal plane, there is coronal malalignment. And I think that is an indicator that the central depression is a larger component to this fracture and may need to be dealt with intraoperatively in an alternative way than just screws alone. You can see here in this blown up view, this fracture it involves at least 60, if not 70% of the articular surface. And I think that was something I did not appreciate as much as I should have when I fixed this. I ended up doing the classic shotgun approach. You can see there's not a lot of dorsal rim left there. Screw fixation with a few mini screws. Thought I was good, concentric reduction, but the patient came back at 2 weeks and is seen by a PA, gets these x-rays and says, go off to therapy, you're going to be fine. That's the first mistake. This is not a true lateral. And I would venture to say that at this point in time, this was already collapsing and failing. And I wasn't aware of it until she came back to see me a couple weeks after that. And sure enough, we have pretty classic redislocation, subluxation, and collapse of the fracture with prominent screws. Now, what do we do at this point? Well, there's a spectrum of options all the way from observation to silicone joint arthroplasty. We're not going to just observe this. I don't think that's the right answer. And closed reduction in casting or closed reduction dorsal lock pinning, I don't think is going to be possible this far out at 4 weeks due to scar tissue formation. Revision ORAF or revision ORAF with external fixation, I think is likely going to fail. I think the bone stock is not adequate. It failed once. Why would it work again? Volar plate arthroplasty is contraindicated, or at least relatively contraindicated, with the extensive involvement of the articular surface. At least with hemi-hamate reconstruction and silicone joint arthroplasty. And I think my take on this is to restore the bony anatomy and articular cartilage with a hemi-hamate is the go-to in this situation. And this is a blown up kind of zoomed in view of the articular alignment. And you, just like Dr. Hastings mentioned, you might think on lateral view on the x-ray that the fragment is not aligned appropriately, yet the cartilage thickness of the base of the hamate is thicker than that of the native middle phalanx, which gives you this false sense that there's a malalignment based on this cortical alignment. So you have to just trust your intraoperative alignment rather than the x-ray. This patient did really well, actually. She came back at a year. The bone graft incorporated nicely. She had a concentric joint motion from 0 to 95 degrees, but she had a DIP joint contracture. And that's another one of these complications that can occur with these fracture dislocations is they do well at the PIP joint, but they end up getting stiff at the DIP. She tried forever to get motion back. Nothing worked. Therapy wasn't working. And we ended up doing a tenolysis at 2 years, which gained her a modest amount of motion, maybe 10 degrees. So not ideal. So this is not one of my best outcomes. I think the hemi-hamate reconstruction turned out great, but overall for a sign language interpreter, I really wanted to get her better motion. This is a 27-year-old male. It was a motorcycle accident. He had an open tuft fracture along with a dorsal fracture dislocation of the base of the middle phalanx. And you can see that there's significant articular comminution and compression at the base of the middle phalanx. And so in this case, I wanted to try to do something more than just screws to maintain alignment. And I went with an old technique using dental wire and a cerclage wire technique to compress the central fragments together and maintain position. And this actually did very well, but he came back 14 months post-op and he had increasing pain. His motion was still pretty good, but he had crepitation that you could even feel with passive range of motion. And for pain relief, I offered him an arthrodesis. He agreed initially, but then canceled surgery. And last visit was in 2018. He never returned. So I assume he's either doing well or he's still in pain. I don't know. But this is just one more classic complication that can occur with these injuries. When you think you have relatively good alignment, you have a concentric joint, you still can go on to post-traumatic arthritis. Finally, one last one, a 31-year-old female, dorsal fracture dislocation, same x-rays as before. We have central depression, small volar rim fragment. I offered her ORAF. In this case, I wanted to do something more. So in each one of these cases, I learned something. I fixed this with mini screws, did the cerclage wire, but this time I added some demineralized bone matrix to, beneath the central fragments to maintain a little bit better articular alignment and support. And she returned at 3 months, very happy with the result, no pain, smooth motion, minimal swelling. She did have a bit of a DIP extension contracture, but what I wanted to point out is that one of the screws is a bit prominent volarly and probably is going to require a hardware removal. So I think, counseling patients preoperatively that these are tenuous cases. We're using hardware that can move. It can cause tendon irritation. There may be a chance for the need for hardware removal down the line. So that's her at 3 months post-op, pretty good motion and minimal swelling. So turned out pretty good. So, complications haven't been reported extensively in the literature. This is, a paper from 1999 in the Journal of Hand Surgery. It was Dr. Stern's group out of Cincinnati, where they looked at 56 patients where they had done volar plate arthroplasty in about 60% of them and ORAF in about 40. They had an 18% complication rate, with the most common one being recurrent dislocation. They had an equal number in both groups, 3 patients in each, so 3 out of 33 ORIF patients had recurrent dislocation. And all of those patients that failed, whether it was in the volar plate arthroplasty or ORIF group, had volar fragment fracture percentage greater than 50% of the articular surface. And interestingly, a third of the patients had greater than 10 degrees of coronal malalignment on their original x-rays. So their take on it was that that coronal malalignment may be a clue that there may be more articular depression and there may be a need for bone graft intraoperatively for those patients. The technique with cerclage wire came out of a paper with Dr. Weiss out of Brown in 1996 in Clinical Orthopaedics and Related Research. And he looked at 12 of his patients at 2 years and had very, very reasonable motion. One patient had post-traumatic arthritis, but there really was no complications related to the cerclage wire itself. There was no implant failure, no irritation of the tendons from the cerclage wire, and he had no infections. A paper out of the Journal of Hand Surgery, British edition in 2005, looked at 19 patients who had either undergone percutaneous pinning, ORIF, or cerclage with open fixation. And their complications included 7 patients out of 19 had some degree of PIP joint incongruity. 4 patients out of the 19 had true subluxation. All of the ORIF patients they reported had some degree of sensory issues. All of the cerclage wire patients had cold intolerance. One of the patients with ORIF, so 1 out of 6, ended up with an infection that was severe enough to require an amputation. And 2 patients with cerclage wire fixation ended up having adhesion formation requiring tenolysis. Finally, JBGS published an instructional course lecture on complications associated with these injuries in 2013. And listed the most common issues with treatment, whether it's operative or non-operative, is stiffness and flexion contracture, chronic swelling, swan neck deformity, and redislocation or subluxation. So it keeps coming up. The ORIF specific complications really are redislocation, and it's almost always related to implant failure or interarticular implant placement. And so their take-home message for ORIF was that injuries with substantial articular surface involvement, more than 50 or 60%, you may need to start looking at some other technique rather than ORIF, which may include, again, Hemi-hamate reconstruction. But in my mind, going into it with a few more options in your quiver, including the cerclage wire technique, and then having some bone graft or bone graft substitute available to support the articular fragments, should be something you keep in mind. Thank you.
Okay, thank you very much, Neil. Everything looks beautiful. I think we all do this, but without the therapy, it's all a failure. So let's have Gary to tell us how he does his magic to get his fingers moving without dislocating. Yeah, Gary, you're on mute.
Thank
There
you.
you go.
Thank you. Thank you very much. And I wish it was that easy. What I hope to do is give some tips along the way of how we sort of manage, because stiffness is obviously a huge problem. PIP is not very forgiving. It's not a very forgiving joint. Just get it advancing here. There we go. No disclosures for this presentation. I'm going to go quickly over how we manage the dorsal volar, lateral, and some of the complex fracture dislocations. And we've all shown the V sign several times, and this is usually, as a therapist, my first encounter with the patient is to make some sort of dorsal block for them. It's very important when you're looking at this to really have an understanding and that there's communication between the physician and the therapist, because that angle that you want to position the joint in can be very deceiving. That dorsal edema is very deceiving. So the joint may look or measure dorsally about 30 degrees, which is the angle you want. But when you look at the true joint angle, it's nowhere near that. So I'll show a couple of good pictures of that just so you can get a better understanding. But it's always good when you're giving orders for how far it needs to be flexed, provide a little margin of error on the flexion side. We've had some success for patients with tenuous stability to do a digital cast, and I'm lucky here because I'll go over and cast them right under, and we'll put it under fluoro and get the joint position right there, and just hold it for a couple of weeks and then start the dorsal block. It's not ideal, but some patients don't want surgery and they want to try the conservative measures first, and we've had some good success with that. Here's another one. It's probably a little easier to see the shadows here. What if you look at the angle of what the joint appears if you stick a goniometer on top versus what the true joint angle. If you look at the one on the left, the joint measures about 25, 30 degrees, but it's still, you can still see that V sign. So you have to bring it down a lot more to get that true 30 degree and that good reduction there. And same with this one, again, a very swollen finger, and it was hard to get it to stay reduced. It's always good to have an x-ray right after you put the dorsal block on them to make sure you're good, rather than send them home and follow up in 2 weeks and find out that it wasn't perfect at the time. So the orthosis position, generally about 30 to 35 degrees of a dorsal block is manageable. More than that, you're pretty much set up for some sort of residual PIP contracture. I usually do either hand-based or digital dorsal block. I used to do the cage. Now I just do everything dorsal. We start them moving. The protective phase, the first 3 weeks especially, we block at about 30 degrees and then allow flexion and extension to the dorsal block. And then about 4 to 6 weeks, we allow an increase of 10 degrees extension per week. And then we start to really focus on managing that residual stiffness. So there's 2 types of orthoses I'll typically use right at this stage to redirect forces to the PIP joint to regain flexion. That one is a relative motion. So you're basically redirecting the flexion force towards that PIP and DIP joints. I also like to use a blocking orthosis, so that it's removable. But again, the MP is the path of least resistance, so we really want to start working on that PIP and DIP flexion. Also, when we're clear, once we're clear for full extension, I'll use a relative motion for extension. Again, in this case, you're putting the MP in relative flexion to the other digits. I'll a lot of times use an extension orthosis at night and then progress to something with light tension and then consider serial casting as needed once full flexion is restored. I always do put the priority on restoring flexion, and then once that's achieved, I'll be a little bit more aggressive on the extension side. As I said, serial casting, if you have full flexion and a persistent PIP flexion contracture, it works really well because it's that long time being held in that position. You just have to check it either once or twice a week to make sure that they don't lose any flexion with it. Surgical management, those were covered nicely in the previous talk. So they range from extension block pinning to ORAF extension or external fixators or the Hemi-hamate. They're managed similarly, that we start with the dorsal block and then gradually progress into extension. Here's an example of a case. Now, this happens unfortunately too often, but this one was treated someplace else in a lumifoam splint, and then 3 weeks after that, it was discontinued and then sent to therapy. Red flags, and I've seen this almost every time. It's very painful with extension and daily activity. And that's sort of a red flag because these patients usually after a few weeks pain isn't necessarily the problem. Stiffness is the problem, but pain isn't so much the problem when they start moving. So I sort of nudged him towards seeing the hand surgeon, and this was his x-ray. He was fracture dislocation. There's his post-op picture. Again, he's now like 4 or 5 weeks out, but we started the comfortable range into flexion with the extension block. At 2 weeks, I started adding the relative motion for flexion. He already had a flexion contracture there at his PIP, so I didn't really worry too much about him, overextending the joint. At 3.5 weeks, you can see it's getting better, but that extension is still very limited, about 30 to 45 degrees. So then I started working in the other direction a little bit more with the relative motion for extension and a static night splint. At 5 weeks, we're getting close, just did some end range for flexion. And at 6.5 weeks, he was very, very close, 10 to 15 degrees of extension and full flexion. So you can still get them even late and make significant progress. I think one of the keys is using those orthoses to facilitate the active motion at the PIP joint and sort of redistribute those forces. So volar dislocations with the central slip disruption, and also that dorsal lip fracture of the middle phalanx. As was talked about before, we'll either do a circumferential splint or a cast. If we're treating conservatively, the timing of immobilization can vary. I do like to do whatever I'm doing with Coban underneath. I like circumferential pressure over it. I like to do these little Coban sleeves, at least to control the edema while the joint is immobilized and the DIP free so they can start moving that. A lot of times the joint is pinned, but whatever the fixation method there is, when we're clear to move, it's the opposite direction. So I'll make them a little template so they know how far to start moving. And I'll just make it usually out of alumifoam so I can measure how far I want them to go safely. Usually we start with a 30-degree arc and then add about 10 to 15 degree per week as long as there's no extension lag. After about 2 weeks with the template, I'll start to do those other orthoses such as a relative motion or blocking to restore the flexion, and then advance to passive motion and eventually to some sort of static progressive or dynamic type splinting, which is almost, with these, I would say almost always I end up making something to restore that motion. And then lastly, lateral, which we haven't talked about too much, but it's these the complete lateral disruption in the volar plate involvement where you need to protect the volar plate as well because of that condylar fracture. We're moving these a lot faster because the surgeons use the internal brace now for the lateral side, but and that lets us start moving them a little early. If there is lateral insufficiency, we use buddy straps a lot, taping towards the injured side, but that does not work well for an index finger or radial collateral or a small finger ulnar collateral, or a small finger in general, because small finger and ring finger don't line up well a lot of times at the joint level. So there are these PIP hinges that I like to use just to give a little bit extra lateral stability. If there is lateral insufficiency, it's always good to start moving with the fingers together at once before individual, and then always protect against that lateral stress during ADLs. And then we see a lot of these now, the traction frame. So I'll kind of walk you through the process with these as far as rehab. It's really important. Sometimes, as many times as they heard from the surgeon that they need to start moving, the patients many are afraid to start moving with the pin sticking out of their finger. So it takes a lot of coaching and a lot of letting them understand that this is made to move, and that it's very important in this phase that they start moving to start remodeling the joint. So we start early right away with early motion as much as is comfortable. Here's a nice example. This is 3 weeks with the fixator out. You can see that a couple things you see is that MP hyperextension and hyperflexion when they try to make a fist. So that's usually a good place to add a relative motion splint to block those motions. And that's what I did. I added it at 4.5 weeks. And at 5.5 weeks, this was the motion. So I never saw him again after that. He was basically went to home program and discharge. Here's one more. This is a ball injury. Same thing. This is the post-op. That's not a great picture there. It's after the fixator was removed. This is 7 weeks post-op, was almost perfect. And again, the orthoses I use to restore motion, relative motion for PIP flexion, I think is extremely important to redirect that force. And then usually about the 5 to 6 week mark, I'm looking at light flexion strapping and something at night to hold them in extension at night. I think the way I try to balance it is flexion during the day as much as possible and extension at night if I can get away with doing that, because that creates that nice balance. So I'm able to work both ways at the same time. So how do I make those decisions? The first thing I'll try to ask them to do is make a claw or make a hook fist. If they have trouble maintaining the MPs in extension, I like to go to the blocking orthosis, which is on the left. If they're making a composite fist, as the picture on the right is, and they're hyperflexing, then I'll go to that relative motion again to redirect the force. If the joint stiffness isn't resolving, I'm pretty quick, 5-6 weeks to go to something either dynamic or static progressive. And then the extension, that my algorithm is usually something at night, just static to start with, along with relative motion. And then the LMDs are a nice adjunct during the day. And then once flexion's restored and there's still if there's a residual extension loss, I think serial casting can work very, very well if the patient understands that they're just going to be in a cast for a few more weeks full time. So the keys to success are always to protect the compromised structures and be careful with that dorsal block angle. Always see if you can see it under X-ray, get X-rays right away, or if you can even form it under and fluoro at the same time, that's even better. Early edema control, early motion is key as much as the stability permits. You want to progress gradually and address residual stiffness when the joint stability permits, and waiting to see what happens is not usually a good strategy for success with these patients. And then I like to use orthoses a lot to redirect the active forces to the PIP joint. Thank you. Let me stop sharing.
Okay. I see there are some questions. One question is, Dr. Hastings, when you do a hemi-hamate arthroplasty, what is can you explain exactly what your post-op protocol is? When do you, what kind of dressing you put on? How do you start moving, and how aggressive are you with the motion? Is it active? Is it passive, or both?
That's a great question. Thank you. Yep. So I put on a Coban type of split of dressing on the single digit, maybe a folded 2x2 on either side, and then some Coban, not tight, just to cut down the swelling. And then I bring them back 3 to 5 days. Like a lot of things in our protocol, it depends on if you operate on a Tuesday or a Friday, right? When you bring them in. So it's somewhere 3 to 5 days or something like that. And I always have someone available, myself or someone else, who's capable, if needed, in doing a digital block in therapy the first time. Because I think it's very helpful to get it going right off the bat. So if they're not comfortable enough, they can't get reasonable motion in their first therapy visit, then we give them a digital block and jumpstart them with that. I usually do keep them in a dorsal block splint, but I've learned that you can go pretty much all the way to extension. So as I've gotten more experience, I almost put them all the way straight if I'm happy with the reconstruction, and that solves a lot of problems after that. I think Gary was really good at showing just a digitally applied dorsal block splint, and in his photographs he showed how important it is to hold the proximal phalanx up to the splint, because otherwise it sags and then creates relative extension. So, and if you're going to need a dorsal block splint, then it's really important to have the P1 secured up to that. And then I'm pretty aggressive in letting our therapists do anything they want for flexion. I tell them that you can apply anything proximally on the base of middle phalanx. It's a little more dangerous applying distal motion that kind of torques things, but if you apply passive motion just beyond the joint, that's pretty safe for getting your flexion. And then I think the tools that Gary showed us for extension. So for me, a digital block to jumpstart them if they're having trouble. The small finger is the worst for me, joint-wise, as well as the ability of its tendency to hyperextend and give problems like Gary talked about. But the hemi-hamates that I've had involving the small finger have been much more challenging than the middle or ring. Fortunately, it's more the middle and ring. Yeah.
When do you allow strengthening?
Yeah, somewhere after 6 weeks, I do. I think they heal pretty fast, and somewhere 6 to 8 weeks, it's fine to progress on with strengthening.
Okay.
The other thing that I've learned is you can't always tell if it's amenable to ORIF or going to need a reconstruction. Someone did a Q&A, should I get CTs? I think if you're really good at analyzing x-rays of the elbow, shoulder, hand, you don't need special studies. But I think for these injuries, a thin slice CT really does help, because just as we've seen in a lot of these cases today, there's a little deviation in deformity because one condylar recess is more impacted than the other one, and a CT can help show you that, and it may help show you if it's really amenable to ORIF. So I'm a big fan. I'm not usually a fan of other extra studies, but for these, a thin slice study can actually give you something in your quiver that helps.
Yeah, I've noticed that sometimes even doing volar plate arthroplasty, if the angle is off, you have to kind of shave out some of the good stuff to make it flat so we can put the volar plate in there, and then that kind of makes you more unstable. So it's a catch-22.
Yeah,
There's
one of the things that led me to this was a guy that fell off one of my horses on my farm. And this was before I've been using toes and things like that before that. And I took his radial styloid and put it in as a graft. And then I used just a burr to shape the condylar recess of that graft and then put the volar plate up into that. And it worked like dynamite for 6 weeks, but then the graft started resorbing and then he redislocated. I think it was a bad choice of a graft. It was a radial styloid with a lot of cortical bone, not enough cancellous. But the volar plate interpose will work if the defect is less than 1.5 or 2 millimeters. And sometimes you can put a graft and put the volar plate in. So if you don't have a hamate, you could still put a bony graft and then shape it and then put the volar plate in between, and it functions somewhat the same.
So when you're done with your hemi-hamate, how important is it to put the volar plate back, or is it causes more contracture doing that?
You know, that's such a simple question. I think Gary could even answer that probably. No, I'm joking. I don't really know. I don't really know. I think you can't.
It's a lot of extra work to get this volar plate. You have to put drill holes or screw holes, somehow anchor it down.
No, it's easy. You know, the volar plate is very thick distally and on each lateral margin. And I just take like a 4-0 suture and just put a single stitch through the lateral corner on each side and put it right into the accessory collateral. And then you can see after you do it, you can see if you can extend the joint all the way. So I don't know, you asked a good question because I've always done it, so I can't tell you what it would be like if I didn't do it.
Okay, I guess next question is for Gary. Can you explain? I think there's a lot of confusion about the relative splint. How does the relative splint help get your flexion contracture improved?
Sure. What happens is when you go to extend, so basically what you're getting is this, right? When you go to extend, typically at the MP joint, force always goes the path of least resistance. So if the MP joint is loose and you go to extend the joint, it's almost think of an ulnar nerve problem with an anti-claw, right? To get that resolved, you need to put pressure down. It's almost the same concept. You're holding the MP joint in relative extension to the other, and you can just stick a pencil in there. I wish I had one at my desk right now, but I'll stick my finger there, and you can push it up like that, and you can see that the force goes right to the PIP joint for extension.
So then how long do they wear this relative splint?
It's nice to wear during activity during the day, as long as flexions, or you can have them alternate between flexion and extension, or if it's mild, you can just have them exercise with it. But again, you're looking when they go to extend, if you see that MP joint hyperextending, you can't hyperextend your MP joint and then extend your PIP joint. So you have to block that down one way or another. So you can block it with the splint or with a hand, but if you just slip on a relative motion splint, then you can go about your business and it becomes a natural part of, it's like therapy while you're using your hand, basically.
And can you use the relative motion for border digits? I think most of what I've seen is the
right.
ring.
Border digits are fine. You just have to have the index and middle, the index and the small in the same direction. So then it rests around there. If it's a interior digit, then you can do a single digit one.
Okay. And one question for Dr. Harness. So when you get all this stiffness, when do you decide, okay, it's time to do a tenolysis? I mean, when is it failure time?
Wow, this just opened up a can of worms. That's complex because, some come in very different flavors. I mean, if you have a combined extension and flexion contracture, you have just the PIP joint or PIP and DIP joint. So you really have to specify what you're dealing with. If it's just a PIP flexion contracture, I will rehab them for at least 6 months before considering doing any sort of release. If it's a issue with tendon adhesion formation, again, I will monitor temporally, what their motion is, and if it's stagnant over a period of 2 to 3 months, I'm going to pull the trigger sometime after 6 months post-op to go ahead and do a tenolysis. With the example that I had earlier, it was a DIP contracture after the Hemi-hamate, and that was tricky because she had no passive DIP motion, and so I couldn't really elicit whether she had a adhesion of her flexor tendons because I couldn't bend her DIP. So we had to release her DIP first to then, unmask whether she had adhesions of the flexor tendon. And once that was done, then go do a tenolysis on the palmar side. And you can see that the result, not ideal, but that's kind of the sequential way you have to look at it.
Okay, well, it's 5:15 now. I think this is the hour of the ending this course. We went over the PIP fracture dislocations. We went over the complications, and Dr. Hastings, our sage, basically reviewed the biomechanics and even the nuances of hemi-hamate reconstruction. And it was a very enlightening session. I thank you all for attending. And hopefully you will follow up on our next courses that's coming up next week and the week after. Thank you very much. Have a good day.